Well, good morning, everyone. Hope everyone's morning has been great so far. Paul, that was an awesome DKA chat. So we're going to talk a little bit this morning about hematuria, which, admittedly is not the most enthralling or super cool topic, but I think it's really important to address because it is something that we see all the time for many, many reasons. So let's go ahead and get started. So hematuria in the pediatric population, the first and foremost thing is a majority of the etiologies are benign. It's usually an asymptomatic presentation that we get on UA because we get it for some other reason. But generally it can be categorized into two sort of trees. So you have your macroscopic hematuria, which is essentially hematuria that you can see, that's visible to the naked eye. And then you have your microscopic hematuria, which is hematuria that is not visible to your naked eye, but there's more than red blood cells when you get the urine analysis. So those are the two, whenever you look at a urine that either looks red or has more than 5 RBCs, that you can sort of categorize. And once you subcategorize, it becomes a little bit easier to break down your differentials for the hematuria. So microscopic hematuria, which is essentially gross hematuria, indicates that there's a small amount of blood. Generally is rarely seen in glomerular disease, but it can also be caused by pigments from like foods and drugs, metabolites. So foods are something that we'll actually talk about because that's one of the really common causes of people presenting, especially in the peds populations, especially kids trying new foods, red foods. And in contrast, the glomerular disease urine is typically sort of the classic cola colored or tea colored urine. It's a little bit more sort of dark brown. And, it's okay if you're not able to tell. You can always send off the urine and kind of go from there. But generally, that's sort of a good, color measure of sorts. And then patients with more vascular bleeding, lower urinary tract bleeding, usually have more bright red, cherry colored blood, which you would sort of anticipate because it would be it'd be more sort of vascular, lower the urinary tract. So microscopic hematuria. So it's usually asymptomatic. We oftentimes catch microscopic hematuria on children that we do urines usually for other reasons. We do urines fairly often, at least in the pediatric population, for many, many reasons. Probably the most common reason that we do it is for fever evaluation, depending on how many days they've had a fever, whether we have a source or not, and we'll oftentimes stumble upon this. In most cases, like I said, sort of in my first slide, it's usually benign. Usually no diagnosis is made after the evaluation. But the one thing to always sort of keep in mind and consider is asymptomatic microscopic hematuria in the setting of proteinuria. I'm talking about not just like 20 protein, I'm talking about more than 100 milligrams per deciliter on the urine analysis, is something to be a little bit more concerned about than your sort of urine that just has a couple of RBCs in it. There is some association with actual significant renal disease that you may have just sort of incidentally caught. Of note, sometimes this is hard to really assess in the ER. Oftentimes, given that a lot of our urines are done on babies and they are done by a catheterization, sometimes you can get blood just from the trauma of the catheter. It can be microscopic or macroscopic, depending on how sort of traumatic it is. And so keep that in mind. And if you're ever concerned about it and you see that, you can always refer them to their PCP and say, hey, listen, here's the deal. There's some blood on there. We think it may be related to the trauma caused by a cath. They can always get a bag sample and then reassess whether the patient has persistent hematuria or persistent proteinuria. And you don't need a sterile sample for that. You just need a bag sample. So just something to keep in mind. So microscopic hematuria plus proteinuria, should always just be like, this patient probably needs a little bit more of an evaluation. Whether that happens in the ER or not is a little bit of a different story. And then, so let's talk about some of the causes, because this is always a little bit fun, is what are some of the causes of red urine without hematuria? Can anyone tell me?
Myoglobinuria.
Okay, excellent. What else?
Rifampin.
Sure. Okay.
Beets.
Yes. Okay. Right. Beets are particularly common foods that are part of food trials for kids, right? Especially if they've never eaten beets before. So that's always something to keep in mind. What else? Anything else you guys can think of?
Porphyria.
Huh?
Porphyria.
Okay, that's an excellent thing to think of as well. Good. Anyone else? Okay, so the list is fairly extensive, so let's take a look. So there are a ton of drugs that can cause red urine without actual hematuria. You know, a lot of these drugs are not common drugs in the pediatric population, so oftentimes we just don't think about it because they're just not prescribed as frequently. But there's a couple of drugs to sort of just keep in mind. Things like ibuprofen is something that can cause red urine. Iron as well. Iron is not a completely uncommon medication in pediatrics. It's not super common, but definitely less than, it's something to sort of think about and keep in mind. Foods, probably one of the biggest reasons. Food and I think myoglobin are sort of stand out in my mind as probably the biggest reasons that I can say clinically that children have had red urine without hematuria. So introduction of beets and blackberries, things with red food coloring, which, if you really think about it, is almost everything. Tylenol, Motrin, pretty much everything has red dye 40 in it. So just something to think about. Mushrooms as well can cause it. So it's just something to keep in mind. And then metabolites, you guys mentioned porphyrias. Bile pigment can also cause a reddish pigmentation of the urine, as well as just melanin, right? And then those are the sort of the big things to kind of remember. You can always refer to this list, so you don't have to memorize this list, but the things that sort of stick out is going to be sort of myoglobin and sort of foods that are probably the most common. So let's talk about a little bit of the etiology of hematuria. We can sort of divide it into glomerular causes, non-glomerular causes, sort of extrarenal and systemic causes. It's a lot of things to cover, so I didn't want to overwhelm this lecture with a bunch of all the things that can cause red urine. We're going to sort of focus a little bit on the glomerular causes today, and then we can always talk a little bit more about all the other things on a different day. So I'm going to ask you guys to participate a little bit more. So let's talk a little bit about differentiating glomerular from non-glomerular causes of hematuria. So what are some things in the history that would make you concerned about a glomerular cause of hematuria?
A recent strep infection.
Okay. Anyone else? No one else? Okay. So let's talk a little bit about it then. So think about glomerular causes of hematuria in someone that's having oliguria, polyuria, recent strep infection is great. So recent respiratory, and remember, not just strep, right? Skin infections as well is something to consider. Strep can cause more than just pharyngitis. Or GI infections, patients with deafness, patients with a family history of hearing loss, family history of renal failure, any sort of rashes, which sort of ties back into that skin infection category. And then obviously medication exposures, depending on what the medications are. We'll talk about the way I sort of look at this chart is I look at one and I remember the other's the other. Of note, something to consider is for sort of non-glomerular causes of hematuria that we see fairly often are going to be sickle cell disease, right? Can cause sort of asymptomatic hematuria that's sort of just there. Don't do a whole lot about it in the ER. But it definitely something, if they have it, should be followed by either their hematologist, which it usually is, or sometimes they'll be referred to a nephrologist for follow-up. And then strenuous exercise, which we talk about with myoglobin. What are some physical examination findings that would make you concerned for a glomerular cause of hematuria?
Edema.
Sorry, couldn't hear. Someone say edema?
Yeah, like evidence of edema.
Yeah, that's excellent. Anyone else?
Hypertension.
Absolutely. Good. What else? I think those are the two big things that we sort of thinking about, and I think that's a great sort of start in sort of the setting of thinking about glomerular causes of hematuria. Sometimes, especially in the peds population, hypertension can be a hard thing to evaluate depending on the temperament of the patient. So if they're crying and yelling through the entire set of vitals, you may not be able to really use your blood pressure accurately. So you may have to wait on that. So just something to keep in mind, but definitely. So hypertension, edema, rashes, right? Signs of arthritis, any signs of sort of pallor is definitely a little bit, should sort of lead you a little bit more towards glomerular causes. And then let's talk about what are some urine analysis findings of hematuria in glomerular disease. And we sort of talked about some of this, right? What the urine would look like a couple of slides ago. So what's the urine going to look like?
The RBCs.
What's the color going to be?
Brown or tea colored?
Like dark cola.
Cola colored urine. So yes, cola colored urine. What else did we talk about that we said would be concerning that may require in the setting of just asymptomatic hematuria that would make you concerned that, hey, maybe this patient needs a little bit more than just this one urine that may require PCP follow-up? What else could you possibly see on a urine?
Like blood and proteins in the urine. Yeah.
Proteinuria, right? So proteinuria, usually protein more than 100 is always a little bit concerning. And then anything else that you can get specifically in hematuria? I'm sorry, glomerular disease?
Red cell cast?
Yes, casts. Excellent. Perfect. So yeah, so you can get brown, tea-colored, cola-colored urine. Proteinuria is often present in glomerular disease. You can get red blood cells, RBC casts. The other thing to think about is, generally they'll have more than about 20% dysmorphic RBCs. And then we'll talk about the lab testing is fairly sort of self-explanatory, but things to consider would be an elevated BUN, creatinine, anemia, which sort of ties into this finding of pallor. And then you guys talked about post-strep glomerulonephritis, right, is something that you guys had mentioned. Or remember, you can also get PSGN with skin infection. So abnormal complement levels is also something to consider. You should rarely have an abnormal BUN and creatinine in someone with a non-glomerular cause of hematuria. So it's always sort of something to consider. And you also really shouldn't be having any kind of casts in the setting of non-glomerular causes of hematuria. Okay. So let's talk about a couple of glomerular causes. So post-strep. PSGN is probably one of the things that's in the forefront of our minds. I think it's also fairly well tested, both on the PEM boards as well as I would assume the ER boards. So it's one of the most common causes of hematuria. Usually you'll get your classic T cola-colored urine. You can also get microscopic hematuria sometimes, but you'll get it in the setting of some protein, which should sort of tip you off that, hey, maybe there's something a little bit more going on. Classically, it's status post URI or respiratory infections. They may not always be diagnosed. So you sort of want to ask more general questions. You definitely don't want to ask them, hey, did you have strep throat? Because they may not know. Remember that strep skin infections lead to PSGN a little bit later in the course, closer to like 4 or 6 weeks time from the time of the infection, which is later than when post-throat infection strep presents with glomerulonephritis. So you may have to go back in your history a little bit further to ask them, like, hey, did you have any other skin infections maybe a month ago or a month and a half, almost 2 months ago? So something to always consider, because I think we always think of PSGN in the setting of strep throat. So just keep in mind that it can cause more than just strep throat. Usually they present with sort of malaise, flu-like symptoms, right, which are very nonspecific and probably what most patients present with, unfortunately, in the peds ER. So it's not the most specific things, just sort of like malaise, fatigue. Oliguria, usually, I think the oliguria can be sometimes hard to assess. I think it depends on how good a historian your patient is, how old your patient is, but it's something to keep in mind. And then the other stuff that we talked about that you generally get with hematuria, which is edema and elevated blood pressure. And as we talked about, sometimes the blood pressure is not the easiest to get, so do your best to try and get a calm blood pressure so you can get something that's a little bit more accurate. And then on your labs, you'll see your classic cast, your proteinuria, usually more than 100 or more than +1. But I think ours is reported in grams per deciliter. So it should be either 50, 100, 150, 200. So look for greater than 100, which should raise a little bit of a red flag. Elevated B and creatinine. This can be normal. You're probably not going to get this without having an abnormal urine in the first place. So definitely remember to even think about it based on your urine. And then you can consider getting complement levels. Usually, these can normalize in 6 to 8 weeks. So depending on when they're presenting, especially if they've had a skin infection, they may not be abnormal, but doesn't necessarily rule out the diagnosis. However, in most patients, the hematuria and proteinuria will resolve in a few weeks. So you can sort of treat them more symptomatically. And we'll talk a little bit later in the presentation about when to refer to the nephrologist or things that would make you concerned to be like, oh, this is a little bit, they need a little bit more than the usual. Go home and follow up with your PCP. The other one to kind of keep in mind, which we don't always think about, is Iga nephropathy, so Buerger's disease. It's due to this glomerular deposition of IgA. It's actually one of the most common pathologic causes of gross hematuria. Also presents, I feel like, with like every other peds condition with post-URI or GI illness. just with gross hematuria, they may not be symptomatic otherwise. Depending on how much they're having, you can have like edema, things like that. But the treatment for this is fairly non-specific. You should definitely, if you're considering this as a diagnosis, get a nephrologist on board. They may consider adding like an ACE inhibitor, a lipid-lowering medication. Sometimes they'll even consider doing like an immunosuppressive therapy. The progression, although this is the most common cause of a pathologic gross hematuria, the progression to renal disease is fairly slow. However, about 15 to 30% of patients that have been diagnosed with this will develop end-stage renal disease. So something to consider in your differential for potential nephrology referral, that they may need a little bit more long-term care. One of the poor prognostic factors for this is a later presentation of disease. They have significant hypertension when they present, or significant proteinuria. I think those are sort of all things to sort of always sort of keep in the back of your mind. Like if you have significant disease on presentation, it's probably generally a good rule of thumb not associated with the best prognosis. So that's that. And then the next one is Alport symptom. I know we talked about earlier when we were looking at that chart for glomerular causes of hematuria. We talked about hearing loss. This is one of the reasons. So Alport disease, or Alport syndrome rather, it's a defect in the type 4 collagen. The presentation can be very insidious. It can be recurrent, persistent hematuria plus proteinuria, which is sort of the case with almost all glomerular disease. Remember, proteinuria more than 100. And usually presents with renal insufficiency, in the setting of a hearing loss. One of the things is any patients, at least most patients that present with hematuria in the setting, with hearing loss, will usually get a baseline urinary workup as well for this. But in the event that you don't see it, that they haven't gotten this workup, it's definitely something to consider. There's often a family history, sometimes there is not. The treatment for Alport syndrome is ACE inhibitors, angiotensin receptor blockers, aldosterone inhibitors, all in the attempt to reduce proteinuria. So just if you're concerned about glomerular causes, just keep, just hearing loss is something to sort of just keep in mind as one of the sort of correlating factors in your history. And then, thin basement disease, which is benign familial hematuria, is autosomal dependent. The presentation is persistent hematuria. One of the things with that's different about thin basement disease is usually is just hematuria that's sort of persistently followed, that is just not getting better after a year, or is rather persistent, after a year. The course is fairly benign. The risk of hypertension, proteinuria, renal failure is fairly low. This would probably just need like a PCP referral as long as they're not having symptoms of sort of more severe disease. And then acute interstitial nephritis can have both microscopic and macroscopic hematuria. We'll present more with the hematuria, pyuria, renal failure symptoms. Usually the offending agents are Motrin, which lots of people get Motrin in the PCR, diuretics, antibiotics, such as like penicillin, cephalosporins, rifampin is something that someone had mentioned earlier. And then sulfonamides. The treatment really is to stop the offending agent. Usually the nice thing about our population is they're not on a ton of drugs, so they're not usually on multiple of these medications to try and figure out which one is causing it. So that makes things a touch easier. So let's review kind of really briefly, what are some non-glomerular causes of hematuria?
UTI.
Someone here said cystitis.
Okay.
Trauma.
What else? So many things. You guys can give me a couple.
Stone.
Sorry, Adrian, I think you said something and I think you got cut off.
Kidney stone.
Okay. What else? And actually, the mnemonic Dr. Sinnert gave will probably give you a bunch of them. Shit, right? So stones, hemolysis, inflammation, infection, tumor, trauma. Most of those will cover. Such a great mnemonic, by the way. However, I don't know, has anyone else heard this, or is this just me hearing this for the first time? So there's a ton of stuff that can cause other non-glomerular causes of hematuria. So UTI is probably your most common cause. And then sort of along the urinary tract, hemorrhagic cystitis, which can be from viral bacterial infections, can be drug-induced. Hypercalciuria, right, can be another big reason for asymptomatic microscopic hematuria or non-glomerular cause of it. And then, kidney stones are really common. Less common, I think, in the pediatric population, probably much more common in the grown-ups. And then your vascular abnormalities, which we don't necessarily always think about. They're not obviously as common, but something to keep in mind. So renal vein or artery thrombosis, hemangiomas, AVMs, and then just anatomic abnormalities, which we do see a decent bit of. So UPJ obstruction, posterior urethral valves. Usually PUV is diagnosed on a fetal sono and primarily diagnosed fairly early in the course of the child's life. They often present with, recurrent symptoms. So but something to consider as well in the event that they are presenting to you. And then other things like urethral prolapse, PKD, and then your tumors, right? Your Wilms tumor, which is a common abdominal tumor, and then any kind of renal contusion or trauma is always a consideration. And then some extra-renal causes of hematuria. I think by and far the most common cause that you're probably going to see is sickle cell disease, at least in our population. And then you have a couple of other things and then strenuous exercise and myoglobin is going to be the other one, probably the two biggies to always keep in mind. And then the other things usually is coagulopathies, including hemophilia, von Willebrand's, and then Nutcracker syndrome is another one to always keep in the back of your mind. But sickle cell and strenuous exercise are the two kind of things to, I think, probably the most commonly seen. So lab evaluation. So, the presence of RBCs and dysmorphic cells are always consistent with glomerular disease, especially if there's more than 20% RBCs. Is suggestive of sort of glomerular hematuria. Proteins are excreted with hematuria. However, gross hematuria should cause less than 2+ protein on a urine dipstick. Any value that's more than 2+ is definitely concerning for glomerular disease. So you should definitely think about that. And if you look at this picture over here, you'll see the samples of sort of gross hematuria in the middle and microscopic hematuria. As you can see, microscopic hematuria looks like just regular urine, nothing whole lot of special about it. But you will see abnormalities on your lab findings. But I think that if I haven't said this enough during this presentation, just remember that hematuria plus protein is, you should always consider a glomerular cause. Always. Okay. And so in terms of ancillary labs for hematuria, it depends on sort of what you're considering in your differential, what your clinical exam looks like. So you can occasionally get a CBC for anemia depending on how concerned you are for it. In patients with abnormal dipsticks, you can consider BMPs. And then complement studies depending on how seriously you're considering immune complex disease like SLE or post-strep glomerulonephritis. None of these are sort of labs that you have to get. I think these are labs in the setting of hematuria that we don't get as frequently unless we're seriously considering something. And then this is the other sort of important thing. We don't see a ton of, I think, renal disease here, but we should know a couple of reasons, or the important reasons of when to refer to nephrology, or when to give them a call, rather. We do have peds nephrology here, so if you guys are unsure, feel free to always give them a call. So microscopic hematuria with glomerular disease, right? Or if you're concerned that the patient has actual glomerular disease, which we talked about almost all of these. Hypercalciuria, you don't have to always, you can refer to nephrology just so they can get a little bit of a follow-up and they can follow along with it. But they should get a follow-up to nephrology if you're concerned for sort of a metabolic disease or a more familial pattern. Hemoglobinopathies with hematuria, they should have sort of a standing yearly evaluation by nephro to make sure that it's not worsening. And then I think, anyone with systemic disease like SLE or Goodpasture syndrome, you should definitely be seeing renal. And then Alport, if you're concerned about Alport syndrome, so if you have someone with glomerular disease, so hematuria, proteinuria with a family history of hearing loss, or patient has a history of hearing loss, not history, or has hearing loss, definitely needs a nephrology referral. Or persistent hematuria, especially if you're concerned that this is maybe underlying thin basement disease, which can just present with nothing other than persistent hematuria, should have a follow-up. So let's talk about a couple of sort of like caveats. So remember, hematuria can account for 3+ protein in the urine. Proteins are excreted with hematuria. However, gross hematuria does not account for more than 2+ proteinuria on a dipstick. Anything more than 2+ should always make you think of glomerular disease. So every patient with microscopic hematuria needs a nephrology referral. No, they do not. So patients with asymptomatic, isolated microscopic hematuria and a normal exam can follow up with their PCP to see if it's persistent. In the event that it is persistent, then they can always get a referral to nephrology. You should have them see their pediatrician within about a week or so they can get it, and they can repeat another one a week later to see if it's persistent. And then patients with hematuria and proteinuria, like I've said, I think 8,000 times in this lecture, you should seriously consider glomerular disease, so you should refer to nephrology if you're concerned about it. So normotensive patients with post-infectious or post-strep glomerulonephritis should be admitted and observed for blood pressure monitoring. No, not always. So patients without significant edema or hypertension can be discharged with close follow-up with a PCP. Remember, the hematuria and proteinuria usually resolves by about the 8-week mark or so. So not always. However, if you're concerned that their hematuria, they're having significant vital abnormalities, so their blood pressure is really high or their edema is significant, you can always consider admitting them. But usually these patients do not need admission. They will need they will need nephrology follow-up, but they probably don't need to be admitted for it. Patients with HSP present with hematuria as a chief complaint. About 50% of patients with HSP present with renal involvement, but they rarely present as hematuria as a chief complaint. Usually they'll present more with the physical manifestation, so the joint pain or the rash that's classic of HSP. But otherwise, very small population of kids with HSP actually develop renal insufficiency long-term, so about 2%, which is fairly small given the number of patients with HSP that you're sort of generally seeing. So let's do just a couple of just questions. I have like 2 or 3. Do I have time, Sophia? I'm not like over, right? Okay. I can't hear you, but I'm just going to do it. Because these are fairly quick. So urine dipstick that is strongly positive for blood with no RBCs on urine microscopy. Can you guys tell me what this suggests? It's a pretty easy one, I think. B?
B.
Yeah, perfect. Sorry, guys, I'm not watching the chat. I don't know if you guys are replying on the chat. Yeah, so concern for myoglobin or hemoglobinuria, right? Perfect. And then beets and mushroom can cause factitious hematuria.
True.
Yeah, yeah. If you've ever eaten beets, they can also make your blood, your poop look red. So another thing to remember, although beets are delicious. So perfect. And then all of the following are criteria to refer a patient with hematuria to a nephrologist, except
B.
perfect. Yeah. So urolithiasis, they do require potentially some metabolic workup to see if this is familial. Definitely, if they have a family history of renal failure, they need a little bit more of an evaluation. And hemoglobinopathy, you should have a consistent renal follow-up. And most of our sickle cell patients should have it. Whether they go or not is a different story, but they should have a standing nephrology referral, usually once a year, just to kind of touch base. I think that's it. I think that was my last one. Perfect. Any questions? Cool. All right. Thank you, guys. If you have any questions after, feel free to let me know. You can always email me, or if you see me in the ER, come find me. All right, guys. It was great.
I just wanted to